Hi, everyone. Welcome. Thank you all so much for joining us today and for being early and on time. We're going to go ahead and get started. Thank you so much for joining us for this 2025 award winners webinar. So, again, this webinar is featuring the 2025 annual meeting Women's Caucus highest scoring abstract award winners. And the collective title is Equity in Action, Innovative Research Addressing Trauma, Screening Gaps, and Cancer Disparities. I'm Michelle Williams. I'm currently serving as the Program Planning Chair for the Women's Caucus. And before we get started with the introductions of our speakers, I just wanted to say thank you on behalf of the Women's Caucus and also to invite you to learn more about our entity within APHA. So the Women's Caucus is dedicated to providing spaces such as this for the uninhibited discussion of emerging topics that aren't often discussed that affect the lives of women all over the world. So if you haven't already, check us out. We have our fabulous website as well as we are on social media sites. And we would love to have you join us. All right, so I have the honor of introducing our fabulous presenters for today. Our highest scoring abstract award winner is Brianna Marshall. Our honorable mention highest scoring abstract award winner is Dr. Lindsay Duzinski. Our highest scoring student abstract award winner is Trey Helwig, sorry. And our honorable mention highest scoring student abstract award winner is Eden Moguez. So I'm going to turn it over to our first presenter. And feel free to post questions in the Q&A box, and we'll also have time for questions and answers at the end. Thanks.
Hi, everyone. Can you all see my screen?
Yes, looks good.
Great, awesome. First, I want to thank Dr. Williams and the APHA Women's Caucus for allowing me the opportunity to speak today. This is an amazing opportunity. And today I'll be presenting a bit of work I did during my MPH entitled Racial Disparities in Cervical Cancer Prevalence in the South Atlantic Region, a cross-sectional analysis. And we had no relationships to disclose doing this work. So getting into a bit of the background about what cervical cancer is, it's the abnormal growth of cells in the cervix, and which is the lower narrow end of the uterus. So there are two types of cervical cancer. We have squamous cell carcinoma, which makes up roughly 90% of the cervical cancers and usually develops in the ectocervix, which is the outer part of the cervix. And we also have adenocarcinoma, which develops from the mucus-producing glandular cells of the endocervix, which would be the inner part of the cervix. So, and other types of cancers that can develop other than these two types are melanoma, sarcoma, and lymphoma. So the biggest risk factor for cervical cancer usually is the HPV or human papillomavirus infection. So prevention and early detection is key, which usually relies on pap smears or HPV vaccination. Since cervical cancer usually develops slowly over time, if it's not found quickly, it can grow and spread to other parts of the body. And the symptoms that may present usually go from no presentation to severe symptoms, including the swelling of the legs, pain in the abdomen, vaginal bleedings, and abnormal discharge. So diving into the numbers a bit, in the US, it's estimated that about 1,100 new cases or 11,000 new cases of cervical cancer are diagnosed each year, and about 4,000 women die from this cancer each year. Something to note is that the mortality rate, so the people who are dying, is nearly 2 times higher in Black women when in comparison to Caucasian women. And then also of note is that in the southern region of the United States, there was the highest incidence rate of cervical cancer. So about 8.5 women per 100,000 people, as well as the mortality rate. And getting into what previous researchers had found, they found that Black women were less likely to be diagnosed with cervical adenocarcinoma when compared to white and Hispanic women. And then there was another study that also found that in the southern regions of the United States, being Black was associated with higher cervical cancer and mortality rates. Then it was also found that within Black women, those who had a lower socioeconomic position faced lower odds of undergoing cervical cancer screening tests compared to their higher socioeconomic position counterparts. So the purpose of us doing this study was to kind of investigate why these numbers were so high in Black women. So we wanted to investigate a potential association between race and cervical cancer prevalence in women living specifically in the South Atlantic region. The states we looked at for the South Atlantic region, we started in Delaware, the District of Columbia, Florida, Georgia, Maryland, North Carolina, South Carolina, Virginia, and West Virginia. And these were states that were classified this way due to like census grouping. So we wanted to look into the South because as we kind of got into on the previous slide, there's elevated rates of morbidity and mortality in people of color living in the South when compared to their white counterparts, as well as being compared to people who might live in northern states. We also wanted to take a look into some of the rural and urban disparities that exist, especially with people who are living in more urban areas might have better access to health care, and they tend to have better outcomes when compared to people living in more rural areas. So the methods of our study, we use data from the 2022 HINTS database, so the Health Internet Information National Trend Survey, and it was a cross-sectional study design, meaning we just took a look at one section in time. We weren't able to follow these participants over time. We looked at about 6,000 participants. We excluded people who had missing data on the outcome, so having cervical cancer or responses that didn't align. And we included all female adults who designated that they were born female, who were age 21 and older at the time of the survey, because that is typically the time that people start getting pelvic exams and pap smears. So when we looked into the assessment of race, it was self-reported and it was categorized into 5 groups. So participants looked at whether they could report whether they identified as Hispanic, Black, or African American, Asian, or other. The assessment on whether someone had cervical cancer, it was not a formal diagnosis. It was whether the respondent put whether they had type of cancer they had, cervical cancer. They could either respond yes or no. And that was a drop down for whether they had ever been diagnosed with any sort of cancer. And when looking at the covariates that we adjusted for age, family history, education, income, census division, smoking status as well. And all analysis we did was conducted in SAS. We just did a descriptive summary of some of the characteristics, and we ran a logistic regression model. So getting into the results that we found that Black women had a higher odds of cervical cancer when compared to white women. They were used as a reference category, as well as Hispanic and Asian women. And when looking at age 50 and 60-year-old women, 50 to 56-year-old women had lower odds of cervical cancer. And that also existed in women who are aged 65 and above. And some of these disparities can be found in this table that we just discussed. So this kind of suggests some significant racial disparities, even after adjusting for some of the covariates we talked about in that previous method slide. It has some significant associations even after adjustment. So that is something of note to highlight. So some of the implications of this, that targeted cervical cancer screening and prevention strategies are needed specifically in this rural Southern community. And it calls for some adjusted screening protocols. So family history should also be considered in risk assessments to enhance early detection. And also some of the limitations we found that it's a potential for unmeasured confounders and the need for further investigation. Also, we didn't include any lifestyle or access to care variables. As I made a note of earlier, with people who live in more urban areas, there's typically more opportunities for them to get screened versus if you live somewhere urban where there may only be one place an hour away where you could get your pap smear or other screening things taken care of. So, for future directions, this is a very interesting topic that people should look into and continue to explore certain socioeconomic and healthcare access factors. Also, to investigate some potential biological or environmental mechanisms that are leading to Black women to have elevated cervical cancer rates when compared to other racial groups. Also, it's important to develop tailored interventions aimed at these high risk populations in order to decrease cervical cancer prevalence. So ultimately, our goal is to try to reduce cervical cancer burden and promote equity in cervical cancer prevention. And these are just some of my references in tables. And I did want to thank the Joint School of Public Health. That is where I completed my Master's of Public Health, as well as my professor for all of their help. Thank you.
Is everyone able to see my screen?
Yes.
Thank you. Well, hello, everyone. My name is Dr. Lindsay Jasinski. I'm an associate professor in the University of Utah College of Social Work, and I'm honored to be here with the Women's Caucus. I'd like to thank Dr. Williams as well as the Women's Caucus for allowing me to present today. So I am a social worker, and I am always excited to be in conversations with public health folks. So today I'll be talking about trauma-informed strategies for engaging and supporting survivors of sex trafficking. So no conflicts of interest to report, but we did receive a small seed grant through the University of Utah Vice President for Research. As many of you might know, human trafficking is defined as the recruitment, harboring, transportation, provision, etc., of a person for the purpose of exploitation. So today for the presentation, I will be talking about sex trafficking. And things that are important to keep in mind are the elements of force, fraud, or coercion in which the person is induced to perform a commercial sex act. This element of force, fraud, or coercion is not required to be in place if the individual is 18 years of age or younger. So some of the background, we know that there are lots of different physical and mental health consequences of sex trafficking. And so the team that I'm working with we're really looking at substance use and harm reduction approaches when we think about sex trafficking. So a lot of the past research has been on identification, but there's less research when we think about after the experience of trafficking or reintegration or addressing trauma. And we also know that survivors of sex trafficking are intervening with lots of different systems. And this may include medical or healthcare settings, but they're not being identified. We also know that survivors of sex trafficking experience a high level of stigma when they're interacting with different service providers. And this might affect their want or desire to continue to interact with systems. And so we're also really interested in service engagement for survivors of sex trafficking, but then also creating trauma-informed systems where survivors will continue to come back to services. So again, there are lots of different consequences, which may include substance use disorder, anxiety, depression, post-traumatic stress disorder, sexually transmitted infections, injuries, and pregnancy complications. And to return back to this conversation of substance use, my colleague recently published a study that found quite a high percentage of sex trafficking survivors experiencing a substance use disorder. So here we see 43% of emergency department visits involving sex trafficking survivors were estimated to have a SUD, and this was higher than survivors of labor trafficking or the general population. And again, survivors will experience stigma and may experience distrust of healthcare providers or other service providers, as well as institutional barriers of care, such as lack of insurance. And so survivors may interact more with the emergency department over different medical services. I just wanted to highlight some of the elements that SAMHSA has defined for trauma-informed care. And these include really an emphasis on safety as well as peer support. And we also have a different project that's focused on peer support, which is really important for survivors, trustworthiness and transparency, collaboration and mutuality, considering cultural, historical, and gender issues, and empowerment, voice, and choice. And so within this presentation, we'll see that autonomy and choice are really key elements when we are interacting with survivors. So again, we know that trauma-informed care can enhance survivor outcomes, and we've seen empirical research on that, as well as their willingness to persist with treatment. But there is lack of research on the impact of trauma-informed care for survivors of sex trafficking, especially when we think of aftercare services and those that approach this issue from a harm reduction perspective. So these results really came from a larger study that was focused on assessing the barriers and facilitators for engaging survivors of sex trafficking in SUD and sexual health services. So trauma-informed care continued to be a theme throughout, and so this presentation will focus on trauma-informed care. And this study was also conducted with service providers who interact with survivors in the Southwestern United States. So we had 21 service providers who participated in the study, which is a 1-hour semi-structured Zoom interview. So we engaged in snowball sampling as well as purposive sampling. Participants received a $50 e-gift card upon completion. Upon permission, participants were audio recorded, and then we conducted thematic analysis using Braun and Clark's model. So some of our characteristics of our sample, which I think is one of the limitations, is that the majority of participants were white, non-Hispanic, cisgender women. About half of participants had a master's degree. Really importantly is that almost half of service providers had been serving survivors for 10 or more years. And so I think this really speaks to the amount of experience that survivors had, and many had served greater than 100 survivors during the past 12 months. You'll notice on the right side of the screen different settings where our service providers worked. So we know that survivors of sex trafficking interact with lots of different systems, and these might be experiences of trying to access services that are not specific to human trafficking. We also know that survivors are unlikely to self-identify. And so you'll notice that we incorporated service providers from lots of different settings, majority from domestic violence and human trafficking settings, as well as criminal, legal, medical, mental health, and substance use disorder services. So our results, there were 5 themes, which included judgment and stigma, building trust through consistency, compassionate communication, survivor autonomy and choice, and a warm and welcoming environment. So I'll go ahead and go through each of these themes with some of the quotes that help illustrate them. So the first theme of judgment and stigma, one service provider who worked in human trafficking services really illustrates how they will work with survivors of human trafficking who say, you know, I tried to get these medical services, but I was really looked down upon. We also saw quite a bit of an intersection, not only with the substance use, but then also folks that are unhoused. And so individuals might experience stigma based on trafficking or these other intersectional identities, whether it's race, gender identity, as well as being unhoused or using substances. And so this quote really speaks to the service provider saying, you know, an individual wants to be treated like a normal person, but they're instantly judged and looked at differently. If you're on a substance, you're no longer treated as a normal human being. They're like, providers were treating me like I was this horrible person, and I've done nothing wrong to them. So just asking for assistance, yet this experience of stigma may prevent an individual from accessing those healthcare services again. The second theme was building trust through consistency. And this is a theme that we continuously heard. One participant worked in outreach, community outreach, and really talked about going to the same settings again and again at the same time, offering some of these supplies, whether it's food, water, harm reduction supplies, and having that relationship really assisted with developing trust, so that if an individual did want to get to the step to seek help, that relationship would already be in existence. So the quote here says, trust is a huge component to reach out, to talk, to seek out help, and being willing to engage and being referred. So these interactions really do take time and trust rather than a one-time interaction. Another theme was related to compassionate communication. So this service provider worked in substance use disorder services and talked about the importance of inclusive language. So using more casual language over formal or academic, I guess to try and just show that I'm not an authority figure. So an intentional effort to disrupt those power dynamics when working with the survivor. Another service provider talked about really sitting shoulder to shoulder with an individual to try to break down some of those power dynamics. Returning back to something we talked about with SAMHSA's recommendations for trauma-informed care is survivor autonomy and choice. This service provider worked in domestic violence services and said, sometimes we have healthcare providers who don't want to let them make those choices, but that means that they're never going to come back and try to get care again. So sometimes a survivor experiencing not having choice or autonomy is really replicative of their trafficking experience when they did experience control and coercion. And so those elements of autonomy and choice become really important. So another participant said, this is your room. You're the boss of everything that happens from this point on. Service providers also talked about the importance of walking survivors through procedures, maybe getting consent again and again to make sure that the survivor was comfortable in that interaction. Another element was creating a warm and welcoming environment. So service providers talked about the importance of the built environment in addition to these other trauma-informed aspects. So this participant worked in human trafficking services and talked about creating a soft space that's warm and welcoming. Even small elements like a candle warmer, snack, water, tissues, just to provide as much trauma-informed care as possible while they're here. So just some implications. We really need to be conducting research that centers intersectionality, and that relates to, again, race, gender identity, class, but then also thinking about survivors that don't fit this stereotype about what an ideal victim looks like. So understanding some of these other intersections. So we learned a lot about elements that service providers are talking about related to trauma-informed care, but a limitation of this study is the lack of survivor voice, and so ensuring that survivors are speaking to the trauma-informed care elements that are most important to them. So future research could include evaluating some of these interventions. We know that trauma-informed care is really lacking in a lot of graduate professional curricula, and so we really advocate incorporating trauma-informed care within schooling. To think about survivors informing trauma-informed care, it's important to partner with survivor-led organizations, speaking to survivor leadership, and then also tangentially, we know that a lot of service providers experience burnout, vicarious trauma through working through these settings. And so really emphasizing the importance of reducing burnout and turnover. So thinking about trauma-informed care beyond the individual level to think about trauma-informed care more organizationally is really important. So finally, some take-home messages. So trauma-informed care is essential. It's really important to address stigma, distrust, and systemic barriers, and to encourage survivors to engage with services, but then also to continue doing so. The second point being that autonomy matters. So survivors having that choice and autonomy can really assist in fostering healing and control over their own situations. The third point of the importance of consistency and compassion. So the relationship is really key in developing that rapport and trust. The last two elements are organizational barriers. So again, turnover and burnout can hinder these trauma-informed care practices. And finally, relational warmth really fosters engagement in these healing environments. So here's my contact information. Please feel free to reach out with any comments or questions. And then I have a QR code here that includes an article of a recently published article. So thank you again. I'm really happy to be here.
Big blue slide visible to everyone?
Yes.
Excellent. Thank you. Hello, everyone. My name is Trey Helwig, and I'm a recent MPH graduate from the University of West Florida. I'm a white man in my mid to late 30s with short brown hair, wearing a white shirt and a black tie. I use he, him pronouns, and am supported by my co-authors and fellow MPH students and alumni, Bridget Brickman and Eliza Williams, and by my coordinators and advisors, Drs. Justice Mbizo and Colette Davis. I'm here to discuss our research titled Targeting the Gaps, Identifying Predictors of Mammography Screening in Florida to Improve Early Intervention Utilizing 2018 BRFSS data. We have no financial support or conflict of interest disclosures to report. As seen in this table, cancer is the second leading cause of death in the state of Florida. While the age-adjusted death rate due to cancer has noticeably decreased over the last 2 decades, breast cancer has remained the second leading cause of cancer-related deaths among women in Florida. For many women, mammograms are the best way to screen for breast cancer and are recommended by the U.S. Preventative Services Task Force for screening women age 40 to 74 every 2 years. Despite this national recommendation, the percentage of women age 40 years and older who report having received a mammogram in the past year has declined from 64.9% in 2007 to 53.1% in 2023. As part of a regional Florida cancer control collaborative, our team seeks to address this cause of death using evidence-based methods to optimize outreach and meet Goal 11 of the 2020-2025 Florida Cancer Plan, reduce breast cancer mortality through early detection in Floridians. To accomplish this task, we aim to identify straightforward, common predictors of mammography screening to target high-risk populations for follow-up. An analysis of the predictors of breast cancer screening compliance in Florida was last completed in 2010. This showed that a lack of health insurance was a strong predictor of poor screening compliance, whereas a woman's age, being married, and having at least a college education were protective factors. There have been no recent state-specific studies creating a knowledge gap in our efforts to address breast cancer screening guidance compliance. Our cross-sectional study used data from the 2018 BRFSS Behavioral Risk Factor Surveillance System to address predictors of mammography screening among women aged 40 years and older in Florida. The study used data from the core questionnaire and the clinical breast exam modules, as this was the most recent breast cancer screening modules available. For the study, responses from 15,242 Florida residents age 18 and older were analyzed. 8,427 individuals were identified as women. Additional inclusion criteria included reported age of 40 years or older and receipt of a mammogram in the past 2 years, resulting in a total sample size of 6,189. The dependent variable was having an up-to-date mammogram within the past 2 years, and predictors included sociodemographic characteristics, access to care, and health behaviors. Respondents who answered not sure, don't know, or were coded as refusing to answer, missing, or not asked were excluded from the sample. This left a final sample size of 6,082. Data cleaning was performed in R. Analyses were conducted in SPSS. An odds ratio was calculated to determine the respondents' odds of having an up-to-date mammogram within the past 2 years, and the relationship was assessed using a multivariable logistics regression model. In the sample, more than 70% had a mammogram within the last 2 years. More than 65% of the respondents in the sample were unable to work, retired, or out of work. More than 60% had a college degree and had attended college or a technical school. The Omnibus chi-square test of model coefficients assessing model fit was smaller, indicating a significant difference between the baseline and new models in log likelihood. The Nagelkirk R-square, which approximates the proportion of the total variance in the data that the model accounts for, indicates that the model explains only 7% of the variation in the outcome. The forest plot displays the odds ratios with their confidence intervals for comparison. For the binary predictor variables, having healthcare coverage, having a flu shot in the past 12 months, having a PAP test in the past, all were significant with a p-value of less than 0.001. For those having had a flu shot in the last 12 months, the odds of having a mammogram within the last 2 years were 1.5 times higher than those who had not had a flu shot. For those who have had a PAP test in the past, the odds of having a mammogram in the last 2 years were 1.5 times higher than those who have not had a PAP test. And for those having healthcare coverage, the odds of having a mammogram in the last 2 years were almost 3 times higher than those not having healthcare coverage. Having graduated from college or a technical school was a significant predictor of having a mammogram in the last 2 years compared to those who had not graduated from high school. For those who have graduated from college or technical school, the odds of having a mammogram within the last 2 years were 1.5 times higher than those who have not graduated from high school. Finally, employment status was a significant predictor of lower likelihood of having a mammogram in the last 2 years. For those who have been out of work for a year, the odds of having a mammogram in the last 2 years were 51% lower than for those employed for a wage. Those unable to work and students who were not significant predictors of having a mammogram within the last 2 years, whereas being retired, homemaker, out of work, or less than a year, out of work for less than a year, or self-employed had lower odds of having a mammogram within the last two years when compared to those employed for a wage. The findings of the study demonstrate that having health insurance, having a history of a PAP test, having received a flu shot in the past year, had higher odds of having a mammogram within the last 2 years than those not having or not having had the predictors. Additionally, the logistics regression model showed that odds of having a mammogram in the last 2 years among those who graduated from college or technical school were 1.5 times higher than those who had not graduated from high school. There was no grading effect across levels of completed education. Being retired, a homemaker, out of work, or self-employed had lower odds of having a mammogram within the last 2 years than those employed for a wage. The population frequency showed that more than 70% of the population was compliant with their screening recommendation in 2018. When comparing this percentage with the 2013 figure of 53%, this suggests the difference in the data cleaning and sample being evaluated. Also, most respondents were not working. This does not align with reported female employment statistics of 55.2% in 2024, although filtering for those age 40 plus may indicate that the overall percentage of women working in Florida is under 40. From our sample, the percentage of Florida women with at least a college degree is comparable to the percentage from 2019 to 2023 of 33.7% of Florida women who had at least a bachelor's degree. With the breast cancer incidence increasing and the compliance of mammogram screening recommendations decreasing, we share the concern reflected in the Florida Cancer Plan and believe additional efforts are needed to better identify those at risk of noncompliance. These findings provide evidence-based indicators for our collaborative target interventions in rural communities where screening rates are lowest. The results found here will provide a starting point for targeting at-risk populations to increase access to screening services. Future, more recent BRFSS clinical data breast exam modules will also provide more up-to-date insights and opportunity for trend analysis. This study used self-reported data collected through a phone survey and employed a cross-sectional design to represent the entire population of Florida. This representation does not account for the regional differences in population, but in prior studies has been found to, on average, reflect the characteristics of the behaviors of the state population as a whole. Future efforts should consider expanding insurance coverage, investing in underserved communities and the Mary Brogan Early Detection Program in Florida, as well as exploring additional barriers to mammography screening compliance and evaluating the effectiveness of current interventions. From this project, we are developing a manuscript using 2018 BRFSS data to identify predictors of mammography screening among Florida women aged 40 to 74 and conduct a stratified analysis to support strategies for earlier detection and intervention. Objectives include estimating the association between healthcare coverage and receipt of a mammography screening and evaluating whether mental health factors mediate this relationship. Our group was also awarded a 2025-2026 Community Implementation Grant for the Florida Comprehensive Cancer Control Program, where we will continue our efforts to increase screening and reduce the cancer burden in Northwest Florida. These are my references. And thank you to the Women's Caucus for the opportunity to present today. And congratulations to my fellow presenters on their well-deserved awards and impressive presentations.
Can you see my screen?
Yes.
All right. Well, hi everyone. My name is Eden Mogus. I'm a recent MPH graduate from the Virginia Medical School, now merged with Old Dominion University, and is a part of the Joint School of Public Health. Thank you for being here today and allowing me to present my research. I'll be sharing findings from my practicum research project examining how maternal adversity and stress are associated with postpartum depression among Black mothers in the United States. This study uses the national data from the CDC Pregnancy Risk Assessment Monitoring System, or PRAMS, covering births from 2016 through 2022. And we have no conflicts to disclose. All right, so for the introduction, postpartum depression, or PPD, is a major public health concern and it disproportionately affects Black mothers. Despite this, Black mothers are often underdiagnosed and undertreated. These disparities are typically shaped by systemic racism, healthcare inequities, and broader social determinants of health, such as housing instability, financial strain, and just limited access to mental health care. While prior research shows how these experiences, like abuse and stress, are linked to postpartum depression, much of that work examines these factors in isolation. There is limited population-based research that looks at how multiple forms of adversity intersecting, especially among Black mothers. This study aims to help address that gap. So for the study objectives, there were two main objectives. First, I examined how different types of maternal adversity, including abuse and multiple domains of stress, are associated with postpartum depression among Black mothers. Then I assessed whether these associations differed for mothers who gave birth before versus during the COVID-19 pandemic, given the additional social, economic, and relational stressors that may have been introduced during that period. So the sample included over 48,000 Black mothers from the CDC PRAMS dataset. The PRAMS is a population-based surveillance system that collects information on maternal experiences before, during, and after pregnancy, making it particularly well-suited for this type of research. Exposure variables were grouped into 6 different domains. So abuse before pregnancy, abuse during pregnancy, partner-related stress, traumatic stress, financial stress, and emotional stress. Postpartum depression was measured using self-reported depressive symptoms, and all analyses adjusted for key demographic and pregnancy-related factors, including age, education, insurance type, marital status, pregnancy intention, prenatal care, and history of depression. To account for the PRAM's complex survey design, I used weighted logistic regression models, adjusting odd ratio, and 95% confidence intervals were calculated to estimate associations between each adversity domain and postpartum depression. Interaction terms were included to test whether giving birth before versus during the COVID-19 pandemic modified these associations. And data cleaning was done in SPSS, and analysis was done on Stata. So for most participants in the sample were aged between 20 to 40 years old with a wide range of educational attainment and insurance coverage. Importantly, many participants reported exposure to multiple stressors. Partner-related stress, financial, and traumatic stress were particularly common. So overall, 46.3% of Black mothers in the samples reported symptoms consistent with postpartum depression. Both abuse before pregnancy and abuse during pregnancy were significantly associated with higher odds of postpartum depression. Partner-related stress emerged as one of the strongest predictors, followed by traumatic stress and financial stress. Together, these findings suggest that postpartum depression risks is shaped by overlapping interpersonal and structural stressors rather than a single experience. So here we see that all the p-values besides emotional stress were less than 0.001, showing how it is significant. When examining whether these associations differed by COVID-19 birth timing, only partner-related stress showed a significant interaction. This suggests that partner-related stress had an even stronger impact on postpartum depression during the pandemic. This may reflect due to the increased isolation, reduced access to external support systems, and heightened relational strain during the COVID-19 pandemic. So for discussions, overall, the findings indicated that maternal adversity and chronic stress substantially increased the risk of postpartum depression among Black mothers. Partner-related stress remained particularly high and impactful across pre-pandemic and pandemic birth cohorts, highlighting it as a critical area for intervention. Key limitations of the studies include its cross-sectional design and reliance on self-reported data. Strengths include the large national representative data set and the ability to examine multiple intersecting forms of adversity. From a public health perspective, these findings support the need for universal mental health screening during prenatal and postpartum care, particularly for Black mothers. They also highlight the importance of provider training to recognize signs of intimate partner violence and chronic stress. Finally, strengthening partnerships between healthcare systems and community-based organizations is critical for providing culturally responsive support beyond clinical settings. Thank you for your time and attention. Sure.
Thank you so very much for all of our presenters. Now we have some time for questions and answers. So feel free, audience, to raise your hand and I can grant you the ability to speak, or if you want to use the Q&A box to ask questions. We have a few minutes left. And also to our presenters, if you have questions about your colleagues' presentations or if you have anything additional that you'd like to share, please feel free. We have a few more minutes. No questions. I mean that you all did an amazing job in clearly relaying information within a very short period of time. So that is absolutely fantastic and excellent. Well, thank you again so very much for taking time out of your busy schedules to join us for this webinar. And again, I have to do my shameless plug of the Women's Caucus so that you all can make sure that you are staying in contact with us. We do like to have webinars throughout the entire year. So if you in the audience have an idea that you would like to present, if you have a topic that you want us to organize a webinar on, please let us know. Feel free to reach out to us. But thank you all so very much. And we look forward to seeing you in 2026 at the annual meeting. But again, I just would also want to say congratulations and continued great work with our speakers. Awesome. Well, thank you so very much. All right. Enjoy the rest of your day. Thank you all so much. It turned out really good. You had a good number of people attending, so that was excellent. I really appreciate you all taking the time because I know it's really hectic going on right now. So,
Thanks for having us.
but thank you so much. And so I will be sending out the recording once the recording is available and posted on our YouTube channel.
Dr. Williams, do you have anything specific planned for National Public Health Week through the caucus?
We don't. Do you have some ideas?
No, well, for our student group, we're a small school, so we would like to think to have to fill out that week from the student's perspective. So if there was something that the caucus was doing, it would be nice to send our students to that event. But no, I don't. Outside of something similar to this, I wouldn't have any other suggestions.
Okay, excellent. Well, I will get with our leadership team to see they may have something planned, and if so, I'll definitely send it over to you.
Thank you. I appreciate it.
Thank you. Thanks, everyone. Enjoy the rest of your day.
Thank you, you
Thank
too.
you.
Thank you, you too.